Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News. We're here in Orlando, Florida at the ASH annual meeting with our on-site coverage. And it's my distinct pleasure today to be joined by Dr. Sidana, the chair of the Committee on Communications for ASH, as well as a world-renowned myeloma expert. Thank you for joining me today.
It's my pleasure.
Okay. So a lot going on here at ASH, and when I read through the abstracts, I read through the journals, there is like a mountain of data for CAR T cells now. And I'm glad you're here to help us sort through some of this stuff. And you and your colleagues have presented here at this annual meeting a long-term follow-up of some patients treated with CAR T cells from one of the CARTITUDE studies.
Yes. So this is very exciting data, Dr. Gerds. So let me give our audience just a flavor of what the trial is. So CARTITUDE 4, for those who are not familiar, is a randomized trial of Cilta-Cel CAR T against standard of care, Dara-Pom-Dex or Dara-Velcade-Dex in patients in early relapse, so 1 to 3 prior lines of therapy. This is the registration trial that led to approval of Cilta-Cel in the earlier line. And previously, we have seen data that it led to better progression-free survival and better overall survival with CAR T compared to standard of care. So what this abstract looks at is different subgroups of patients. Standard risk cytogenetics, how do they do? Earlier this year at the ASCO meeting, I had the privilege of presenting data in the high-risk subgroups. And yes, with CAR T, the high-risk subgroups do better than compared to standard of care. And many of us are actually doing a lot of early-line CAR T for high-risk patients. But then we wanted to look at what about the standard risk patients? Because what works in high risk actually works much better in standard risk patients, right? And this data just solidifies that. Patients who are standard risk based on cytogenetics as defined by FISH, at 2.5 years, 80% of them are alive and progression-free. So only 20% of patients progress in that 2.5 years after getting the CAR T. So these are patients who are out in the world, who are living their life without any treatment. I mean, that is remarkable. So yes, it works great for high risk. We should definitely do it, but it works even better for standard risk patients. So I think this is just paradigm changing for our patients' CAR T cells, because in myeloma, we've always had this continuous therapy paradigm, right? And so now we have a one and done therapy. What complicates though is bispecifics. And so I think that'll be the fight between the CAR T and bispecific. But again, one and done, very powerful, continuous, very powerful.
So you mentioned that kind of this like tug between bispecifics and CAR T cells, and obviously that's centerpiece. And it again, it is phenomenal that we're able as a field to walk away from continuous therapy in some part. Where does this leave transplant? I remember, this is a long time ago, Dr. Kyle getting up and saying there's no better drug in multiple myeloma than melphalan. But where does transplant fit in with all these things now?
I think that's an excellent question. So every time we've tried to challenge transplant, it's kind of just stood its ground, right? Against RD, against VRD. But I think maybe in cell therapy and CAR T cell therapy, transplants met its match. Of course, we have a big randomized trial ongoing, CARTITUDE 6, which after the best induction therapy we have, daratumumab, VRD, patients get either a transplant or Cilta-Cel. I think that trial's fully accrued. Of course, we are eagerly waiting the results. It might take a year or two to even see some very, very early line data. It's a 750 patient study. But that study will tell us, at least for effectiveness, if there's another therapy which can match it. And I think CAR T has a real potential, honestly, in terms of effectiveness, the MRD negativity that we see with CAR T in the late line setting. To me, it's highly likely that would be a positive trial. At least that's what I'm hoping.
And in 2-3 steps ahead too, you can kind of picture how this can get in the community more, right? So like right now, transplant has to be done at large academic centers types, and same with CAR T cells in large part. But in the future, if it's shown that CAR T cells are as good as transplant, and then we get like maybe off the shelf kind of CAR T cells or in vivo CAR T cells or something like that, boy, you could go to your local doc and get your total therapy there, or what? Not to
The
use the
total
term.
therapy.
That's the wrong term to use in
Pre-transplants.
myeloma setting, but like a complete appreciation for what care you might need as a myeloma patient, even closer to home, which I think could be huge for many patients across the country and across the globe. I think really in terms of access. So I think this is super exciting. Not only the next steps with these future studies that you're mentioning, but potentially down the road.
Completely agree. And to your point of in vivo CAR-T, tomorrow for our late breaker session, we have an in vivo CAR-T data being presented that all of us in the myeloma community are very excited for, along with a bispecific combination, right? So there's just a lot happening in myeloma. So I don't think in 5-10 years we'll be using transplant.
It's an amazing prospect for sure. Yeah. Well, thank you so much for coming by and speaking with us here at ASH Clinical News. Appreciate your time. And you can read about this abstract and all of our on-site coverage in ASH Clinical News.